So how does our body manage shock? And we already talked about homeostasis and how our body likes to be in its perfect normal. And our body constantly increases, decreases vascular resistance, increases, decreases heart rate, increases, decreases respiratory rate, increases, decreases insulin release, whatever, trying to maintain a state of normalcy. And that's where our body likes to be. And when we start losing blood or losing volume or start seeing effects of shock, then our body has already started making changes well before we even see signs and symptoms of it. So what happens is you start having your sympathetic nervous systems kick in. And so one of the things our body wants to compensate, so how does it compensate, is through the sympathetic nervous system. So if we are losing blood pressure, there's a couple ways to increase it. One's you're going to increase cardiac output, and you can either increase stroke volume or you can increase heart rate or both, and trying to increase blood pressure. And we also can increase systemic vascular resistance. So we can increase one or all three of those factors: the stroke volume, heart rate, or vascular resistance. So, and that's regulated by the hormone chemicals, mainly epinephrine and norepi, that's released from our sympathetic nervous system. So our sympathetic nervous system stimulated, it releases epi, norepi, it increases heart rate, it increases stroke volume, it increases vascular resistance, trying to maintain blood pressure. So that's when we're saying we're compensating. So you have compensating shock or decompensating shock. So compensating shock is our body is making waves and is managing it okay. Now, if we don't stop whatever the problem is long term, our body may not be able to handle it. So in a case of somebody who has hypovolemic shock, what has our body done? So our body has probably already increased heart rates, increased stroke volume, or tried to increase stroke volumes, increase heart rate, increase systemic vascular resistance. And that works to an extent, but if the bleeding is not stopped, then we're constantly losing volume, then eventually we get to a point that we have no volume to pump. So then we would go in more of a decompensated factor. So compensated is we see some slight changes in the vital signs, but blood pressure is compensating. With decompensated, we're seeing these signs and symptoms: elevated heart rate, increased respirations, etc., but our blood pressure is not being compensated. So compensated versus decompensated. There's a third classification of shock known as irreversible shock. And irreversible shock, the body's just unable to maintain anything. So we first start compensating, then we go to decompensating, and then if not corrected, we go to irreversible. And irreversible shock is just as it says, it's pretty well irreversible. And when you go to irreversible shock, we're also looking at multiple organ dysfunction syndrome, multiple organ failure, etc. And then we just lead into a cascading effect. And that's one thing that shock does. If intervention is not taken early and quickly, we start leading into a cascading circular downward spiral. So if you have somebody who's losing blood, if you do not stop that blood loss by either direct pressure or tourniquet, then that patient's still losing blood. You lose blood, you lose circulating blood volume. And our body can only vasoconstrict so much, it can only increase heart rate so much, and to the point that it cannot compensate anymore. In the case of neurogenic shock, so if we have a spinal injury, say from around T4 or T5, and from that point down, we've lost vascular tone, which means we've increased container space beneath that injury point on our lower extremities. So our body can't relate to epinephrine there because we've lost that chemical, we've lost that neuro function. So we can't vasodilate in our lower extremities, but we can vasodilate in our upper extremities. That's why in some patients with neurogenic shock, you have flushed red skin or flushed skin on the lower extremities. You may even see a priapism with these patients. So if you have flushed skin, why is there flushed skin? Because we've vasodilated, we've opened up container space, blood's kind of pooling toward in all these extra cavities, and we've increased that container space. So blood starts getting toward the skin, and that's why we get flushed. However, we may have compensatory mechanisms above the injury site, and then you would have classic signs and symptoms of pale, cool, clammy skin. So with a neurogenic shock, you have the upper arms may be pale, cool, and clammy because it's still compensating. It still relates to that epinephrine sympathetic nervous system stimulation, where lower extremities may not. So those are looking at clues, ask investigation questions, etc., to try to figure out what's going on with your patient. If you can't figure out why your patient has a drop in blood pressure, you need to start asking more questions if it's just not so obvious. Again, is it related to what stage of shock, what form of shock is it? And now your textbook and there's other information that talks specifically about compensating versus decompensating, what the blood pressure would be, what your heart rate would be. Would you see an increase in respiratory rate, decrease in respiratory rate, etc. So I'm not going that great in detail on in this video, but just know that if you start losing blood, your heart rate's going to increase. And if you're maintaining a blood pressure, you're compensating. If you're not maintaining a blood pressure, or it's low blood pressure while compensating or trying to compensate, then you're decompensating. So those are the broad 1,000-foot overview of these categories. So how can we fix this? Well, first we have to figure out what the cause is, and then we start relating. Sometimes we treat specifically the signs and symptoms, and if we can know what the cause is, we'll still treat the signs and symptoms, but if we can treat the cause, that's ultimately what needs to be corrected. Now, what I went over was, again, just the different causes of shock, the different classifications of shock, the different etiologies of shock. So with shock, it's either a pump problem, a piping problem, or container space problem, or a volume problem. If you have a problem with any of those, your body should have compensatory mechanisms in place to try to compensate. But if it's extreme, then your body may not be able to compensate. Then you would go into decompensating, if not irreversible shock. And our goal is to keep our patients alive and keep them out of irreversible shock. However, their injuries or illness could be so bad that we may not be able to do that. So we looked at the classification of shock: distributive, obstructive, cardiogenic, and hypovolemic. But with those, we're broken down even more within the different causes. So cardiogenic shock is a pumping problem. Obstructive shock is caused by anything impeding blood flow or blood flow from or to the heart. Hypovolemic shock is the loss of blood or blood volume. And then we have our distributive shock, which we have an increasing container size. So again, do your assessments, read the material. If you have any questions, I want you to reach out to me and I'll try to clarify as much as I can.